It's now my pleasure to introduce my friend and savior when I had a coughing attack last year. Dr. Tiffany Beckman came to my rescue, and she is our next speaker. Tiffany is an enrolled member of the Leech Lake Band of Ojibwe, and she is an American Indian physician scientist and the first American Indian endocrinologist of adults in the nation. She's an assistant professor of medicine in the Division of Diabetes, Endocrinology, and Metabolism at the University of Minnesota, and her interests are in prevention, treatment, and cure of obesity and type 2 diabetes. So Tiffany is going to speak to us about brain activation by food cues with choice of visual stimulus in obese American Indian women. Please welcome Tiffany.
Bonjour, ha matakoyapi waisan, minugiji God. Hello, all my relatives. It's a beautiful day today. So I'm sorry about the title of my talk. That title was due a long time ago when I didn't have my slides done. So there is a slide with that title on it, but there's only one. I realized that there was something else that I really wanted to talk about, and it's sort of a blessing. I was driving here, and I realized I actually forgot the files I needed anyway to present all of that other stuff. So what I'm going to talk to you about today is, can diabetes be cured? And I think that's an important topic. And if you look at my slide here, you'll see some symbols on here. The Association of American Indian Physicians and Leech Lake Band of Ojibwe. I'm from the Leech Lake Band, and for those of you who don't know, Bugganagishig is one of our great leaders and ancestors, and he was the last Indian standing against the United States government in 1898. And I don't mean for that to sound disrespectful. He was standing up for our sovereignty. And anyway, y'all can read about that. You can look that up, and there's a school named after Bugganagishig in Bina, where my family's from. And in the old Indian way, we have strong kinship ties. So I'm here with honoring the Shakopee Metawockatan Dakota community because I was asked to be here and help with some things. And I'm honored to do that. And back in the olden days, in the old Indian way, there are some stories, and I won't talk about our families and how they grew up together up north and what they did and all that, because they're not here. You know, most of my family's passed away, and my auntie's not here, so I'm not going to talk about specifics, but all I'm going to say is our tribes have each other's backs. We've got each other. We'll take care of each other, and that's why I'm here. And for all of you in the audience, I'm a physician, so know that if you need some help, I've got your back too. So without further ado, I better get on with this talk here. We'll be here all day, right? So can diabetes be prevented? Everybody knows that. We're always talking about special diabetes program for Indians and prevention. But few people will talk about, can it be cured? The answer is yes. And many people, when they lose weight, often they can lose diabetes too. And I'm not going to go over all the medical complications of obesity because there's not enough time for that. There are entire symposia on that could last years. Anyway, a lot of the stuff's reversible, and I think that's what I want to give you is hope. So these are some de-identified patient cases of people that I had the honor of taking care of. And so the first one is a 47-year-old man who is seen at the consult request of Dr. Z for morbid obesity, associated with a number of conditions, including diabetes, depression, alcoholism, high blood pressure, high cholesterol, and the like. He felt his initial weight gain was associated with the use of ketapine, which he was given for depression and sleep. When you get further history, you find out that he was actually taking in quite a lot of caloric beverages, and you can see on the slide there what those were. So I'm not going to read that to you, but there's a lot there. He also struggled with homelessness and some other problems. He was on insulin and oral medications for diabetes, blood pressure, cholesterol, and high blood pressure. So some interventions were done, and we had him meet with one of the nutritionists to get a good structured 1,500 calorie meal plan. And he began to work out an hour every day. And there was a CD intake assessment and treatment plan. And I started him on naltrexone, 50 milligrams a day. It's a medication that blocks overactive reward pathways and addiction emotion centers in the brain that also control food intake. It's a nonspecific opioid antagonist. Anyway, I'm not going to bore you with the pharmacology. So I started him on that to block some of the strong carbohydrates cravings that he was having. And a lot of that was for alcohol. And alcohol is a carbohydrate. Other diabetes management. So we discussed the need for monitoring for hypoglycemia. And those discussions were many. Anyway, the patient cut out the beverages with calories in them, all of them, and switched to water. And he said that the naltrexone really helped him with the cravings. He successfully lost 50 pounds. So the diabetes status, well, he didn't need his insulin or his oral diabetes medications anymore because we were able to meet the widely accepted standards of care without them through his lifestyle changes. Blood pressure status, similar story. Normal blood pressure, didn't need the diuretic and the ACE inhibitor anymore. And as for the cholesterol, well, you can see the LDL met the goal without the statin. So that's one success story. And here's another one. This lady, 52-year-old, diabetes, a whole number of medical issues you can see there, cognitive disorder, learning disability, inability to read, physical limitation using an electric wheelchair, also seen at the consult request of another doctor, surgeon, Dr. Z this time. So the patient was pursuing bariatric surgery and needed to lose 15 pounds prior to surgery. And that was in 2010. So I'm going to show you the neuropsych evaluation on the patient because I think it's important to look at barriers. And this is what was described in the chart. Moderate mental retardation with mildly to severely impaired performance across cognitive domains. Uncooperative, irritable, sullen, resentful, angry. At times she would face the wall. And you can look at the rest here, but the point is there were a number of barriers for this patient. And there was a longer assessment that sort of went on and on from the neuropsychiatric standpoint. I'm not going to read it all to you. But there were concerns about judgment and insight and ability to follow directions and instructions. And so there were a variety of cognitive and psychosocial concerns that may affect ability to participate in treatment plan, and so on and so on. So the idea here was that neuropsych didn't clear the patient for bariatric surgery because of concerns with the ability to do some things. Anyhow, the patient refused to work with a psychologist or a psychiatrist. And that's fine, because tender, loving care goes a long way. It's one of the best medicines we have in the world, actually. And all it involves is just listening to someone and appreciating their diversity and letting them know that you want to take care of them. And so she worked on a number of things, reducing portions of foods and liquids, caloric liquids, and you can see the physical activity limitations and things that she had done there. There was some pool therapy involved as part of the rehabilitation plan. So there were some other interventions as well that I just thought I would mention about medications associated with weight loss that I had her taking, and those are listed here. And what else should I say here? So one thing I did is try to empower her about her neuropathy and her nerve pain and treating the vitamin B12 and convincing her that treating that and weight loss would help restore the circulation to the nerves. And hope is powerful medicine. So she has actually exceeded expectations. If you recall, she was only asked to lose about 15 pounds. Anyway, she lost 117 pounds. And that was as of 2013. So you can see the time interval it took her to lose that. And last time I saw her, her net weight was down 121 pounds without bariatric surgery. And she's still taking insulin and metformin and some other medications. And one day I saw her and I noticed the blood sugars some of them were in the 200s. I asked about pop. She got a funny smile on her face and looked down and kind of laughed and said, "What pop?" And so anyway, you need to follow these patients and really continue to provide that feedback that's needed for lifestyle change. So why do people overeat? I'm not going to read this to you because I think we could all answer questions around that, or I think we all know, but there are many reasons, and it's governed largely by the brain. Habit, circadian rhythm, hunger, craving, mood management, food availability, circumstance, pleasure, reward, social events. I mean, the list goes on. So I'm going to interrupt that thought with a little bit of American Indian history, and I'm going to put this slide up here, and I'm not going to review all of it because we would be here for a very, very long time. And I will say it was 119 years ago this week that there was that battle that Bug-in-a-Geeshig was involved in up north. And I laugh thinking about it because you can't buy sovereignty. Okay, all these bad things happen to us as Indian people. I mean, a lot of things, right? That sort of shape the decisions we make and some of the behaviors we have and achievements we make or don't make. And anyway, but sovereignty is priceless. You can't buy it. And so that's one thing that I learned from my ancestors. So I'm not going to let this history get me down. Heavens no. So there's a study that I worked on for quite a while, and you're only going to see a small portion of it today because I have a number of steps that I have to complete. And quite frankly, I don't think that me presenting a whole bunch of neuroscience to you would be of benefit to you and to your communities. And I want to be able to give something today that will be helpful. So there's going to be some discussion of this modality we call functional neuroimaging. And the reason that I chose that modality to study neuroscience and the neurobiology of obesity is, well, you already know, you saw that if we can help patients to lose weight, that they can lose a number of diseases. And it's a good non-invasive method, and it's translational. So you can take work that you've done in the bench and basic science work and translate it into something meaningful for humanity. You can really use it to map function to anatomy regionally in the brain and look at what areas of the brain are involved in particular situations. And it's what we use to understand the neuroscience in fMRI is something called BOLD. It's blood oxygen level dependent response. So it's really a surrogate marker for neural transmission, essentially. It's following the regional blood flow after the neural activity occurs, after the stimulus. So I wanted to ask the question, does brain response to food cues differ based on the food depicted? Well, the answer is yes, and my colleague, Dr. Ellen Scher, in Seattle, had done a study in lean women that were 2.5 hours postprandial, or they had eaten 2.5 hours ago. And what she showed is that there is activation in the brain that is in different regions, and it depends on what you're actually looking at. And so you can see here there's some areas of the brain, the striatum and the amygdala, that are involved when people are looking at fattening food versus non-fattening food. And those areas of the brain are important for a number of other things that I won't talk about because I want to get through everything today. These are some of the stimuli that were used in our study. So the study that we did here was similar to the one that Dr. Scher did, using the same food pictures. And we had women in the scanner, the MRI scanner, after an overnight fast and after placebo, and they were looking at these pictures. And you can imagine what their brains were doing when they were seeing some of these pictures. These are some of the low-calorie visual stimuli from the study. So our participants were American Indian women living in Minneapolis, BMIs between 30 and 57. There's also a lean group, right-handed, and in neuroscience, we don't want to argue about left-handed, right-handed, and right and left hemispheric dominance in the brain, but so we had to control for effects of handedness in the study, and also control for the effects of age. So I wanted to include everybody, in the community who wanted to be in the study, to have them be in the study, because a lot of people wanted to do this, and I had a limit and say, oh, no, we got to control for age effects, on the brain, and so that was hard, because I want everybody to benefit and everybody to partake and enjoy, what I was working on. So that was hard. So here's the one slide that relates to the title that you see in the planning book. This is it, one slide. Brain activation by food cues varies with choice of visual stimulus in obese American Indian women. And this is just showing that there are some areas in the brain that are involved with addiction, memory, and reward that activate when these women look at pictures of high-calorie versus low-calorie foods. And there would be more, but like I said, I was driving down here and I left all of my research files to prepare this talk at home, and I'm like, everything happens for a reason, Benici Quaid. Consider it a blessing. Your talk's being planned for you by the higher power, so deal with it. Anyway, that's the slide. There will be more later because I'm going to have a number of community dissemination events. And anyway, I don't want to bore you with all that stuff I got to do yet. So what I want to do is give you guys something you can bring back to your families and your communities and something that'll help. And you probably already know this because there's a lot of professionals in the audience too, so I don't want to insult your intelligence, spend a lot of time on this. But this slide is up here just because I had to put some things in here about weight management. And this is about calories. And it's about energy in and energy out at the end of the day. And you can see on the left-hand side, there's body weight in one column and suggested energy intake in another column and an approximate calorie deficit in another column. And I will tell you that this is an important guide, but I have a lot of patients who do not count calories, and they do just fine. They lose weight, and everybody has to decide what they want to do and how they want to do it, and you have to support that and empower them in their lifestyle changes. I will share with you something from the National Weight Control Registry about behaviors that were associated with long-term success. And the people in this registry had to keep 60 pounds of weight off for 2 years to be enrolled in the registry. And people, like me, were interested in seeing, well, what did they do? What sort of things did they do to be so successful? Well, they did some self-monitoring, so they kept a record of their dietary intake and checked their body weight once a week or more. And they followed an approximately 1,300 to 1,400 calorie energy intake. They ate breakfast daily and had regular physical activity to the tune of about 4 miles a day. So I think those are important cardinal behaviors for people to look at and try to adopt in some way into their own lifestyle. So I like to tell patients when they come into clinic that the first goal in the clinic is not to gain any more weight and work on getting fit. And there's another study I won't talk about fitness in elders who weren't in the study to lose weight. And actually, they didn't lose weight. And the increase in the physical fitness is what protected them from cardiovascular mortality and morbidity, so deaths from heart attacks and strokes. And so they did well just by getting fit. The other goals I like to set for people, or help them set, are to lose 5 to 10% of body weight over 12 months, because that's what's associated with the clinical benefit. That is the reversal of some of the diseases that I described on some earlier slides. And these are just steps that are needed to begin defining a goal, identifying obstacles to the goal, determining the changes needed to meet the goal, and setting a date. So, why lose weight? To prevent, treat, and even cure diabetes. I recently told one of our tribal leaders at our annual Wachipi that as a native physician, I wholeheartedly believe that with good nutrition, we can prevent, treat, and cure most of the diseases of the Western world. So I have to put something in here for people that are either have diabetes, have it in their family, or are helping manage community members and patients with diabetes. This is for vascular risk reduction. This is what is needed to reduce the mortality, the deaths, and morbidity from heart attacks, strokes, and blood vessel disease. Think of it like the plumbing in your house, or the plumbing in your house and the veins and the arteries in your body. So to protect that vasculature, those blood vessels, you need to know your ABCs. A is for A1C. It's 3 months' worth of blood sugars in one blood test. The widely accepted standard is to have that be less than 7%. B is for blood pressure. Here's a goal, 130/80 or less. There are nephrologists and cardiologists who will argue about that, and they can based on the clinical context of the patient, but I think this is widely accepted. C is for cholesterol, so LDL goal less than 100, and this has been widely debated between the Endocrine Society and the American College of Cardiology recently, and I think what I heard at the NIH this past week was that we were going back to these standards again with the numbers. And S is for smoking cessation. So, preventing complications of diabetes involves controlling the ABCs, getting regular eye exams, dental exams, foot exams, doing good foot care, taking baby aspirin a day if there's no contraindication, that is, no bleeding history, quitting smoking, and controlling body weight. The rest of the slides are acknowledgments, so I think I'm actually going to finish on time despite getting a later start. The people on the slide have been mentors and have done a lot to help advance the work. And on the right, you see a lot of students and coordinators and community program specialists. And I could tell you about each community that each of these girls are from, but I won't, because then we will run over. And I wish they were here to talk about their own communities, but when people talk about community-based participatory research, I have to laugh because, you know, we have a lot of community members in our study who are helping do the work and making decisions about it and helping, you know, the girls, and everybody's benefiting. This is how some of these folks launched their careers, actually. So Chelsea is now a registered nurse, and Lily is now a registered nurse, and I could go on with what these girls have done. Lisa is an advocate, and it's funny, one day in the lab I said, gee whiz, I can hardly focus on this medical research when people are dying in our community. What we need are some Indian health advocates at these hospitals. We need one person at each post to make sure that when our people come through the hospitals and the clinics, that they're well cared for and they're protected. And so Lisa, bless her heart, one day she was gone and she had a new job as the Indian health advocate at Minneapolis Children's Hospital, and I'm so proud of her. Anyway, and then Carrie Day is helping us with some public health problems in the Little Earth community, and she's on the ground. And Juanita's here. I'm sure you all know Juanita. She's done a lot for our arts community and around philanthropy. And it's an honor to work with her. At the university, we have this hierarchy. People are, anyway, they get all up in that. So-and-so works for so-and-so. No, in our community, she's an elder and a grandmother. And she knew my grandmother. So it's all beautiful work. There are a number of acknowledgments that I'd like to make here as far as the grants that helped with this work. And a lot of these are the first grant is a K Award, Career Development Award. The others are center grants that funded the Center for Magnetic Resonance research and other infrastructure that's important to advance work like this. And, I was telling someone the other night that, I don't like staying up all night writing grants and stuff, but I have to laugh because it's the one way we Indian people can hold them accountable and make them pay and honor our treaties in a very strategic way. So anyway, that's what gives me the passion to go ahead and keep writing them, especially in the face of these impending budget cuts. We have to be even more strategic and work harder. I'd like to thank the Indian Affairs Council for helping with study recruitment and information dissemination. And the Shakopee Metawakan Sioux Community and University of Minnesota Healthy Foods, Healthy Lives Institute for making this beautiful conference possible. And I'd like to thank Mindy Kurzer for her tireless enthusiasm. And I've learned a lot from her about leadership, and I'll continue to learn from her. So here's a quote that I'd like to share. There's a lot I'd like to share, but this one it's a really good one. So here's a Cree prophecy. When all the trees have been cut down, when all the animals have been hunted, when all the waters are polluted, when all the air is unsafe to breathe, only then will you discover that money cannot be eaten. And I feel that here because I stood up in front of all of our tribal leaders at an Indian Affairs Council meeting that I got to late. I had to drive like the wind, like Grandma always said, to get to places. She didn't like me driving like the wind, but I had to get there because it was important. I stood up and I told them that, my name is on a lot of trust and tax land up north, and that I will die protecting our land and our rice and our water. And that's what I will do. It's where I'm from, and it's what I believe in, and it's what I will do. And that there is no money that will ever make me change my mind about our pipelines and about that work that's constantly threatening our livelihood as Indian people. And so anyway, this heartfelt quote is something that I wanted to share with you because there's people that are a lot smarter than me that came before me, and I want to honor them. So I want to leave you with something. Remember that hope is medicine. And with our sovereignty and protecting our sovereignty, that brings hope to all of us and to our future generations. And I want to say medicine and science are a lot like art. And so here's a quote from Vincent van Gogh. He said, "What would life be if we had no courage to attempt anything?" Miigwech, Padamye.
Are there data to show that diabetes and obesity rates will go down if or as people change their diets to consume more traditional food?
Yes, and I think we've heard about that. That's the whole point of this conference and this initiative, is to help us get back to our traditional life ways and our traditional foods, and to reclaim things that we think we've lost but we really haven't, and to remember what we think we've forgotten about where we come from and where we're going, so we can all be healthy.
How do you see trauma being healed as a part of the treatment of obesity and diabetes? What are some of your favorite approaches or referrals to resolve trauma? Any good books that you can recommend?
I think that's a very insightful question, and that's a lot of what we do in medicine is healing, and there's a lot of trauma, and I think it's important to recognize that and help that person heal and help populations heal in order to overcome these modern diseases that we have, like diabetes and obesity. Because through the healing comes improved self-care and good lifestyle changes, and there's a nice echo effect. And one of the strategies that I think is effective is when I talk to a patient who's having trouble doing self-care and they're talking about some of the barriers, I like to remind them that in order to be here, to take care of their kids and grandkids and their nieces and nephews and their community, that they have to take care of themselves first. Otherwise, they're not going to get to do all that good stuff they're struggling to do and that they want to do in the future to make other people's lives better. And that because we have a strong sense of community as Native people, that's really one effective strategy. As far as referrals, I try to make what are considered appropriate and effective referrals to people, so that I share my patients with others who I think can help heal them. And the patients don't always want to go, and frankly, I think some of them just they get spoiled rotten, and they go, well, why do I have to go see a counselor if Dr. Beckman's going to, she's going to listen to me and help me work through this? And I try to tell them, you know what, there's people that have better credentials to do that, But I guess you got to find the people that listen with their hearts. And as far as good books, there's probably a lot that others could recommend. And right now, my brain is bookless because my slides were done at 4:30 this morning. So.
You're doing great, Mindy. Here's another question for you. Many of our people try so hard to manage diabetes, but the alcoholism is a shadow behind the diabetes they don't discuss. They can't change. How can they be helped, if at all, while still drinking?
So you saw the de-identified patient case that I presented, and I think it was a nice interdisciplinary approach to that patient's care. I didn't try to help that person all by myself. I made some really good referrals, and he really wanted help. He said to me, I don't want to be taking all these medications, and that was his biggest motivator when he realized all these medications he had and how expensive they were and side effects, and he's trying to worry about having a place to live. He didn't want to have all those meds. And so I think that you got to find out what motivates the individual that you're trying to help and listen to them and give them some tender love and care and give them hope. And people in the sciences call it a motivational interview, but it's just about caring and listening and tailoring your help and your interventions to that person and to their needs.
What is your perspective on those with diabetes who have a normal BMI or who are not significantly overweight or obese? Do you still say it can be cured?
I guess it depends on the individual, how long they've had diabetes, and there's also some metabolic parameters that would need to be looked at and examined in order to better make that determination, because there's such a wide variety of diabetes that's out in the community. And while we can change a lot of genetic expression through lifestyle change with improved nutrition and physical activity, there are some things that are more difficult to change, and so I have to be respectful of that. But this field of epigenetics is very wild and interesting, and it gives me hope to know that we can change the genetic expression through lifestyle. There would be things we would look at, specific metabolic parameters in someone with a normal BMI. I would get that history, and I'll tell you, there's a story. So I was driving up to Wisdom Steps one year, and I was in the car, and I'm praying while I'm driving. I'm like, I really need some answers here. How come my colleagues always tell the patients you will always have diabetes forever? that sickens their spirit and their emotion and their selves. It sickens them, and then they believe that and walk away, and their head drooping, So I wanted an answer, and it's so funny. My question was, how long could someone have diabetes, and how much weight would they have to lose, and how much insulin would they be on, and could they still get rid of their diabetes, right? So this elder walks up to me after I gave a talk at Wisdom Steps, comes up, tells me her personal story, and said that she had lost 100 pounds on her own, was on 200 units of insulin a day, and no longer needs any medication to control her diabetes, and really doesn't have it anymore. It goes in to get monitored, but it's actually gone. So that was like my answer. It came through the gift of an elder. But as far as the normal BMI, I would collect a C-peptide and look at endogenous insulin production, and again, take that history of how long they've had diabetes, family history, and sort of what are their dietary patterns. And I would probably still approach it with a higher protein, isocaloric diet. And I would try to not have to use insulin in that patient, and try not to start medications for diabetes that could be associated with weight gain, so that the things don't get worse.
Thank you. Tiffany.
Oh, and one more thing I forgot. You can actually, people think they need a shot of insulin after they've eaten something, and they might, but an experiment that's worth doing, this is an example of good research in our community, is to have the patients go and take a walk and then recheck the blood sugar and learn about that other way of disposing of glucose, getting rid of that sugar. So anyway, I just wanted to put that out there because I don't know how many people have heard that. Thank you.
Terrific. Thank you. Wonderful.